Good afternoon to everybody east of Thunder Bay and good morning to the west. Welcome to the Canadian Patient Safety Institute's 6-part webinar series focused on knowledge translation and implementation science. My name, as Tricia mentioned, is Christopher Thrall. I'm the Communications Officer with CPSI and I will be your MC for the webinar. I would like to welcome you on behalf of our web host, Tricia Swartz, CPSI Patient Safety Improvement Lead, as well as our technical host, CPSI Project Coordinator, Monique Thibodeau. Our call today is the third of 6 in this informative series, building on the second session by focusing on the question, once we have the evidence to justify implementing a new patient safety initiative, what's next? This session is designed for participants to consider the importance of clarifying who needs to do what differently at which level to promote implementation. While this series is best enjoyed as a whole, of course, you are always welcome to attend any one, several, or all 6 webinars in the series. If you miss a webinar and you want to catch up, please know that all are recorded and available on our website the week following their webcast date. So it gives me and CPSI inestimable pleasure to introduce our speakers for this webinar, Dr. Jeremy Grimshaw and Dr. Justin Presseau. Dr. Grimshaw received a Bachelor of Medicine, Bachelor of Surgery degree from the University of Edinburgh in the United Kingdom. He trained as a family physician prior to undertaking a PhD in health services research at the University of Aberdeen. He moved to Canada in 2002. Dr. Grimshaw's research focuses on the evaluation of interventions to disseminate and implement evidence-based practice. Jeremy is a senior scientist in the Clinical Epidemiology program at the Ottawa Hospital Research Institute, a full professor in the Department of Medicine at the University of Ottawa, and a Tier 1 Canada Research Chair in Health Knowledge Transfer and Uptake. He has been Director of Cochrane Canada and the Coordinating Editor of the Cochrane Effective Practice and Organization of Care Group. In 2015, he was elected co-chair of the Campbell Collaboration and became Corresponding Fellow of the Royal Society of Edinburgh. Dr. Justin Presseau has a PhD in psychology from the University of Aberdeen. He has been awarded early career awards from the UK Society for Behavioural Medicine, the International Society of Behavioral Medicine, and the European Health Psychology Society. He is an associate editor for the journals Implementation Science and Applied Psychology, Health and Wellbeing. Dr. Presseau is a scientist at the Ottawa Hospital Research Institute and an assistant professor in the School of Epidemiology and Public Health and the School of Psychology at the University of Ottawa. He is the scientific lead for knowledge translation at the Ottawa Methods Center. Dr. Presseau's research program operates at the intersection between health psychology and implementation science. He draws upon behavior change theories and methods to understand factors that promote and undermine behavior change in healthcare settings, and then designs and evaluates theory-based strategies for promoting healthcare professional behavior change to increase best practice and reduce non-evidence practice in healthcare. Dr. Grimshaw and Dr. Presseau will talk for approximately 40 minutes, allowing us 15 minutes at the end for questions and conversation. Please write your questions and comments in the question and answer box or the chat box, and they will be compiled and provided to our speakers at the end of the call. If you run into IT difficulties, please connect with us in the chat or question and answer box, and we would be happy to assist. Without further ado, CPSI is delighted to welcome our speakers for today, Drs. Jeremy Grimshaw and Justin Presseau.
This is Jeremy Grimshaw. Hi, this is Jeremy Grimshaw. I think Justin is going to kick off the presentation, and I think we're just waiting for his sound issues to resolve. Justin, are you there? I mean, if not, if you're still having problems, Tricia, maybe if you put the slide up, I can start the presentation.
I think he was just on mute, Jeremy. I think we're good to go. Justin, are you there now? No, perhaps not. Jeremy, why don't we pass back to you while Monique works with Justin in the chat box to resolve the sound issue.
That's great. So could you, I can't see the slides just at the moment, Tricia. I don't know if you can put the slides up. That's great.
Yes.
So I apologize to participants for the slight technical hiccups that we're having today. Justin and I, even though we're both based in Ottawa, are at in different sites. I'm currently speaking to you from St. John's in Newfoundland, whereas I think Justin is in Ottawa. So I will start off the presentation and do the first third of this. I do hope that Justin is going to be able to join us because he was going to do the second third, and if he can't, I'll do my best. But I'm sure you'll have a better time with Justin. So what we want to do this time is just really, remind you about the key frameworks we're using during these webinars and where this seminar or this webinar particularly fits in. We want to talk a lot about sort of identifying evidence practice gaps, and in particular then thinking about scoping out what the problem is by identifying who needs to do what differently, and also introducing a framework called the TACT-A. So we'll keep going. And if you remember, this is really the reason for this webinar series and the work that CPSI is now doing, looking at how behavioural and implementation science approaches may be able to advance this work. That if we are trying to implement patient safety programs, we need key actors, sometimes patients, sometimes healthcare providers, sometimes managers and policymakers to change their behaviours or decisions whilst they're working in the complex healthcare environment, which could be thought of as ordered chaos. And there is a very substantial evidence base in behavioural sciences that we can lever that will hopefully increase the likelihood of success of the implementation of patient safety programs. So this is the third of 6 webinars. In the first webinar, I gave an overview about KT and implementation science, or just what I did. And last week, we gave you a webinar on knowledge creation and synthesis, particularly emphasizing the need to look for evidence to support both the clinical care and the implementation approaches that we use when we're trying to develop patient safety programs. And this week, we're going to talk about who needs to do what differently to promote implementation. And you can see we've got 3 further webinars after this. Whoops. There we go. And in webinar 1, we introduced this framework, the knowledge to action framework that was developed by our colleague Ian Graham that many of you may be aware of. And this sort of basically talks about a knowledge creation funnel, which is a central inverted funnel, and an action cycle. And the knowledge creation funnel was really the whole basis for our conversation during webinar 2. So that if you missed that and you want to go back to that, as Chris said, basically, and these are archived on CPSI's website. I think Justin is now joining us, but maybe Justin, I'll keep going until the end of my slide, and then I'll hand over to you if that would work for you.
Sure. Can you hear me?
We can hear you beautifully. I'm so relieved.
Wonderful. Apologies for that.
Okay, so I'll just keep going over the next couple of slides. Oops, sorry, I skipped over. So the focus of this webinar is really helping identify the problem as the start of the action cycle. So the outer action cycle describes a series of steps that healthcare organizations can undertake if they want to try and plan successful implementation programs. And typically we start off by sort of basically talking about sort of identifying what the problem is. And in the action cycle, it highlights 2 different ways in which problems can come to the fore. The first is that we may have a problem, a critical incident in our own healthcare setting that stimulates us to action. So, if we had a terrible event like an asthma death in the emergency department, or we had high rates of hospital-acquired infections, that local data might sort of stimulate us to say, what can we do to try and improve patient safety and culture here? Or it could be that that new knowledge comes out that actually stimulates us to look at our own practices. So it could be that, for example, there's a new WHO program on patient safety, as there has been in the past for hand hygiene, and the development of these new programs from WHO or CPSI again acts as a stimulus for us to think about our patient safety practices and all the things that we could do that would be better. So typically, when I work in the Ottawa Hospital Research Institute, and we often get approached either by research colleagues or clinical colleagues who are facing a particular either patient safety or implementation problem. And one of the kind of key messages that Justin and I would like you to get out of this and actually future webinars is, in our experience, healthcare professionals and managers are very focused on solutions. That's how we've been trained. And so what we have found typically is that people often will jump to a solution without really understanding or defining the problem and understanding what's driving the problem. And a lot of the work that we'll talk about today in the subsequent webinars are really saying, if we want to try and be more successful in our approaches, we think that we should be trying to be much clearer in specifying what the problem is and then understanding what are drivers to the problem and barriers to overcoming it. And so when someone comes into my office with a particular problem, I often do some initial scoping work and then go into a sort of a more deeper specification of what is it you're trying to change. But these are the 5 questions that I typically use when I'm approached by someone with a problem. So I ask them, what is the behavior or series of linked behaviors that you're trying to change? Because often it's not a discrete behavior, but actually multiple behaviors that are linked together that we need to change if we want to improve an aspect of safety. Who performs behaviors? So who are the kind of who are the clinicians or the staff who are involved in this? When and where does the potential adopter perform the behavior? Are there obvious practical barriers to performing the behavior? And is the barrier usually performed in stressful circumstances? Now, the reason for the last question is it reminds me, I think in general, most healthcare settings are highly stressful, and we're asking healthcare professionals to undertake difficult, complex decisions and behaviors in time-pressured, chaotic, slightly stressful circumstances. And under those conditions, all human beings tend to make mistakes. And so the reason for having this 5th question is to say we anticipate that one of the drivers of unsafe practices is just kind of basically the mistakes people make because we're human beings. And when I ask this question, it's really helpful for me to sort of almost use this to visualize, well, what's the clinical environment and who are the kind of clinicians involved and what are they doing around the time when we're trying to basically think about behavior change. And I find that often if you use these series of questions, it helps really focus people on the sort of the problem in very practical terms. And I want to give you just a quick example of where this was helpful. Almost about 20 years ago, I visited the Royal Women's Hospital in Melbourne, in Australia, and I had a meeting with their quality group, and they said their number 1 problem was poor active 3rd stage of labor. So this is once the baby has been delivered and once the placenta has been delivered, you want to give the mother an injection of a drug which will constrict the blood vessels in the womb and reduce the likelihood that the mother will have a bleed. And this is still a significant cause of postpartum morbidity in Canada and around the world. It can actually is a common cause of death in less well-developed settings. So this is a major problem for obstetric circumstances. And the people in the women's hospital said, we've been trying to work on this for years, and we're just not getting traction. So I kind of basically asked them these questions. And so there's, in terms of what is the behavior that you're trying to change, there are 2 behaviors here. One is that someone has to recognize that the placenta has been delivered, the afterbirth. and the second is if someone has to basically give the mother the injection. Who performs the behaviours? Well, in Melbourne and in Australia, they have a midwife model, so that there's one midwife who's been with the mother throughout labour, and whose job it is to basically both deliver the baby and deliver the afterbirth. But once the baby has been delivered and the afterbirth has been delivered and the mother's stable, then that midwife switches into roles which are about supporting the mother, encouraging bonding with the baby, encouraging sort of early lactation if that's possible. But there's also a second midwife who's coming to the room during the second stage of labour when the mother is pushing. And normally, once the baby's been delivered, the placenta's been delivered, that midwife will help basically clean up the room and tidy up the room, and then go on to other duties. So we have two behaviours and two people in the room. When and where there's potential adopt form of behaviour, and are there any obvious practical barriers? Not really. These are kind of these are behaviours done in the delivery room, and everything that is needed by the staff are there. And actually, this is something which is probably an area where it may not be that stressful. After most deliveries, this is something that needs to be done, but it's actually a time of reducing stress when the mother's actually delivered the baby. So I ended up with a conversation that said, okay, so we have two behaviours and we have two people in the room, two clinicians in the room. Who should be responsible for recognizing that the placenta, the afterbirth, has been delivered? And it became very clear that actually the midwife who's charged and is responsible for the delivery of the afterbirth should maybe do that. But then, who should actually give the mother an injection? And it also became clear that it would not be appropriate for the midwife who'd delivered the baby in the afterbirth to give the injection, because in reality we want that midwife to do, to provide a lot of social support to the mother, the baby, the significant other who's there in these early hours. But you have a second midwife there who could easily give the mother this second injection. And what I observed and what the quality group said to me is making the problem not something abstract like active third stage of labour, but saying what has to change to actually make sure this safety procedure is actually delivered, and change the conversation. And the room started to buzz, and they started to have different kind of conversations than they've had before. And I typically found that we often tend to sort of make our problems very abstract. And if we can get people to think about them in very practical terms, it starts to allow them to think about them in different ways. And so I'm now going to hand over to Justin, who's going to sort of describe or how we can go to the next stage of really being very specific, or defining the behaviours we're trying to change in very specific ways. So Justin, can I hand over to you?
Yes, brilliant. Thanks very much, Jeremy. And apologies again for my IT issues. Of course, it was deliberate so that I could emphasize the importance of scoping the problem in terms of, in particular, who performs the behavior. The last few have relied on Jeremy, and clearly I should have done a bit of a scoping of the problem to anticipate that issue. But let's keep going. So as we did with the first webinar, we thought it might be helpful just to have a similar generalizable example case study to provide examples for some of the points that we want to make. And so this will be familiar to those of you who are on the first call, but and for many of you who are familiar with hand hygiene issues in general within the patient safety literature. But for those of you who aren't, we know that healthcare-associated infections are a top 10 cause of hospital-related deaths worldwide, affecting 1 in 10 patients in hospital. Compliance in terms of hand hygiene remains a problem across the world. No one has necessarily solved this yet, with average reported compliance rates right around sort of half the time, without really strong evidence or understanding of why compliance is not any better than that. And so, as I say, we'll use this case study as an exemplar as we walk through some of the tools and examples over the next few slides. But also to re-emphasize, and I'll mention this again at the end of the webinar, that we're keen to involve examples from any of the initiatives that you yourselves on the webinar might be involved in. So please do send through any examples that you think might be helpful for us to tackle or to incorporate within the next few webinars. We've done that. A few of you have sent some through already, and we've endeavored to include some examples within this one, but the more you can do that, the more we can tailor the webinar to ongoing initiatives alongside this example. So Jeremy nicely laid out the knowledge creation funnel in the last webinar in terms of which ultimately produces some sort of knowledge product, whether it be a systematic review, perhaps a clinical practice guideline, a policy brief, a decision aid, and he also nicely warned of sort of buyer beware that there's varying quality of some of these this evidence base, but nevertheless, if we take for granted that the quality is good and that there's an evidence base that we might want to implement, for example, a recommendation for hand hygiene, it's not necessarily the case that just disseminating that evidence will lead to change in practice. So the first step is really to really understand what the problem might be of moving that evidence into care by clarifying what evidence practice gaps might be in place. So first of all, we need to ask ourselves, what do we know about whether there is, first of all, any discrepancies between what those knowledge products might suggest and what care is actually being provided. And there may well be a gap to identify there. And identifying that gap or that first level of the problem helps to focus attention on whether, first of all, what the solution might be, but also to ensure that there is a gap to address, that we're not just creating solutions for non-problems. And depending on your resources, there may be a range of ways to identify those evidence practice gaps. For instance, there could be opportunity to do local audits in your jurisdictions or do observations. There might be research papers that are generalizable to your particular setting that actually quantify some of the gaps in care, or there might be national or international organizations that have done that at a larger scale. But first, pinning down what that evidence practice gap might be then sets the stage for the next step, which is always now what we know that there's an evidence practice gap to address. What do we do? So the traditional approach, which we briefly touched on in the first webinar, is what we might call the Islagiate approach, or it seemed like a good idea at the time, where a group of administrators might set a meeting and brainstorm solutions, for example, how do we address this hand hygiene issue? And lots of good ideas are probably highlighted, and ultimately someone makes a decision on which solution to move forward with, and it then gets implemented, and we sort of cross our fingers and hope that it works. And it may be that some of those solutions work, but we don't necessarily know whether the solution is actually fit for the evidence to practice gap necessarily. And so an implementation science-based approach would, and I think we're going to sound like a broken record by the end of this, but before jumping to solutions, we definitely advocate trying to dig down into the problem to understand it in more detail, so that we can increase the likelihood that whatever solution we select is better fit to address the problem at hand, rather than jumping right to the solution itself. And so then moving on to how do we operationalize that, what we advocate using is the French model. So we touched again on this in the first webinar, but this is four key questions or 4 steps that you might ask yourself in terms of really pinning down the problem of, first of all, who needs to do what differently, which is what we're going to address today, in terms of whose behavior needs to change and what those behaviors might be, what factors determine whether or not they do, or in other words, barriers and enablers, and what strategies can be used to address those factors. And those link on nicely from each other. And so we'll be addressing those, the second and the third and the fourth of how do we actually measure change in subsequent webinars, but we really thought it would be worth emphasizing ways in which we can unpack specifically who needs to do what differently, and tools for doing that in this webinar. So again, thinking through why do we why do we consider a behavior change approach as a useful one to take? And so we proposed that if you think about it, if it's a guideline that's being produced in that knowledge creation funnel, or a technique, or a medication that needs to be prescribed, a new medication that needs to be introduced, or in some patient safety circles, possibly a medication that needs to be de-implemented, or possibly a new policy, or ultimately a safety practice. I know one of you on the webinar, on the first webinar, sent us an example of an initiative called the Speaking Up Initiative in clinical practice to try to reduce power imbalances. But ultimately, whatever the case may be, in order for these to be implemented, someone in the healthcare system's behavior or actions need to change in order for it to be implemented. And as we mentioned, by framing it in that way, we can draw on what we already know from the behavioral sciences about how people change and what factors drive change. But in order to do that properly, we need to unpack and clarify what are the specific behaviors involved in those people that need to change. And of course, we talk often of the healthcare system and healthcare providers, but clearly patients and citizens are essentially important in this process because they are involved, are recipients of and involved in their care as well. And so whether it's a new technique, a medication being introduced or removed, or safety practice, in many, if not all cases, patients and citizens' behaviors might need to be altered as well, whether it might be asking questions or attending healthcare appointments or engaging with their healthcare team, requesting care, taking or not taking medication. These are all behaviors as well that are not necessarily a given, that may have their own sets of barriers and enablers and strategies to support patients as well. And so we absolutely recognize the importance of both those in the healthcare system as well as patients and citizens alongside whose behavior is equally important. So another way to think about this question of who needs to do what differently, when and where, typically we start off by unpacking the who, so usually starting with the circle of care. So we take hand hygiene practices as an example. What is the key healthcare professional that we're focusing on? Is it the family doctor in primary care? Is it a nurse or nurse practitioner? Are we talking about surgeons in the hospital, or maybe pharmacists or dentists? Who specifically needs to do the hand hygiene? Of course, within that are patients as well. We talked about that. But also more generally, the wider people in the wider organization may have a role to play in ensuring or setting the stage for those in the lower concentric circles. And there may be higher levels as well, but department heads and CEOs and administrators and higher up may well have important behaviors in their own right. And framing what they do in behavioral terms may help us to unpack exactly what might help or stop them from doing what they need to do in order to set the stage for the initiative to run. So after unpacking the who, we can then be more specific about the what. And what we mean by what is the specific, observable, measurable behaviors that we're talking about for each of the who that we focused on. And so even when we're talking about hand hygiene, it's not a particularly specific way of describing what people do. What do we exactly mean by hand hygiene? It could be washing hands, like in the picture, or we might be talking about using alcohol-based gel to sanitize hands. And so though the way in which we describe that what may have substantial implications for how what barriers and enablers might be in place and what strategies we might put in place to address them. But of course, hand hygiene is just, or using alcohol-based gel is just one of many health professional behaviors. There might be ordering tests or not ordering tests, communicating, referring, scanning, prescribing or not prescribing, examining, providing. There's a range of different behaviors that we might focus on. Equally, not only with the health professionals, but higher up within the organization. As we mentioned, setting policies and providing infrastructure are ultimately decisions and behaviors at a higher level that have their own potential factors that might impact on them. And equally, patients have a role to play in understanding and specifying exactly which behaviors we're interested in have an implication for addressing that evidence to practice gap. Now, crucially, once we identify the who and the what, we need to unpack the differently. How is the behavior different from what's normally done? And that helps to clarify expectations on all levels. And so one useful way of distinguishing how a what behavior might be different is by asking ourselves, is this a behavior that someone needs to start completely new? Is this a new behavior? Is this something they're already doing but they should be doing, or hopefully we want to encourage them to do more of or less of? Or maybe we're hoping that they stop entirely, and if so, possibly replace it with something new. And distinguishing between these may also have implications for the barriers for introducing something new are potentially different from doing more or less of something or stopping entirely. And in particular within the field of implementation science, the distinction between the do more and do less and stopping is increasingly being an area of focus, and highlighting that there are different strategies for each of these types of or ways of characterizing behaviors that we might need to think about. And if there are different strategies, there may well be different barriers and enablers to those distinctions. Now, once we identify those first three components, we then need to pin down when and where. And so again, this is about being specific to clarify expectations from those that we're ultimately identifying barriers from, and how we actually end up measuring whether they've changed. And so when we talk about a when, this is important for identifying exactly what counts as doing the behavior. Are we expecting them to do it every day, multiple times a day, every week, during every shift, at every opportunity, under specific circumstances, before seeing a patient, with a patient, after a patient, or is there a deadline? All of these features, while they may seem possibly even pedantic or overly specific, there may be distinctions in barriers and enablers depending on what the expectation is or what counts as doing it. And unpacking that when identifying ultimately barriers and enablers and introducing strategies to address them may be important, rather than leaving it at a vaguer level for people to make assumptions about. And then finally, the where, in a similar way to the when, is about, again, being specific. In some cases, it might be obvious, especially to those who are already involved, but it may be less so to those that are newer to the setting, or if the behavior is substantially new that needs to be performed elsewhere. Are we talking about the hallway, the office, the consultation room, the bathroom? And these actions may differ depending on where they need to be performed. And so this is all about emphasizing being specific may help to unpack and identify barriers in a level of detail that may not have been possible if we just describe it as hand hygiene at a very high level. And so one tool that we found particularly helpful in unpacking the who, where, when, and where is something called the TACT-A. So TACT-A is really just an acronym that stands for Target, Action, Context, Time, and Actor. And was the first four were originally proposed in the 60s by a fairly influential social psychologist, Martin Fishbein, who was trying to clarify, to make the case that if we're wanting to understand and change what people do, we need to, as we were saying, make it clear exactly what we're talking about from a measurement perspective, measure the behavior, but also to ensure that any factors that we want to understand that determine that behavior need to be described in as much detail. And so TACTA proposes that we highlight the target. And so this is the person with and for whom the behavior, the action is directed. So if we're talking about hand hygiene, this might be the patient is the target of the activity. The action being performed might be using a hand sanitizing gel. The context is where the action is performed, so it could be specified as in the hallway outside a patient's room before and after they go in. And the time is the action which is performed, which could be, for example, specified as immediately before entering the room. A colleague of ours proposed that Fishbein's TACT should be extended to also specify the actor, which, in other words, the person who is doing the behavior, which may seem obvious when we're talking about hand hygiene, but when we start to think about other types of important clinical actions or behaviors that we might want to focus on, like prescribing or test ordering, it may not necessarily be the case, may be clear who that person is unless we unpack it in more detail, who's actually signing off and ordering the tests. And so being specific about who is personally doing or should be doing the behavior is worth unpacking, because really it helps to provide clarity on the behavior that needs to change and ultimately how to measure whether that's changed when we go to evaluate. And we propose that you may find this tool useful in your settings to, even within 5 to 10 minutes, to clarify who needs to do what differently, when and where, and thinking about a particular initiative that you might be involved in planning or engaging in within your own settings. So if that's the case, we thought it might be helpful just to provide some examples of a sort of an elaborated TACTA tool with a couple of behaviors. And so again, just to re-emphasize that clearly specifying the behavior in terms of the TACTA can help also to make the guidelines or even the products of the knowledge creation funnel more behaviorally specific, so that's clear what the recommendations are in behavior terms. Helps to focus what we assess in terms of barriers and enablers, select techniques and strategies, and ultimately measure behavior change. And so we have a version of this as a PDF, which we've found particularly helpful in a range of settings and working with different stakeholders. And so if it might be of any use, we're happy to send through a PDF of that, or you could just use your. It doesn't necessarily need to be within this PDF, but if that's helpful, we're happy to send that through. But I thought it might help to give two examples of one of a do more and another of a do less behavior. So we think of a do more behavior, which might be characterized as hand hygiene. An elaborated TACTA would be for the action. We specify the behavior that needs to change in terms of a behavior that can be observed and measured. So as I was saying, hand hygiene is not necessarily specific enough, so we might say using alcohol-based hand gel, which focuses our attention down. The actor in this case for a given initiative might be staff physicians, nurses, and residents in a hospital. The target, so the person or people with and for whom the action is performed, ultimately are patients receiving care at the hospital. The context might be the patient's room in the hallways, and the time when the action is performed might be before and after any time they touch a patient. But as mentioned, the health provider side actors may not be the only important actor to focus on, and so we might think the hospital administrator is an important behavior, set of behaviors to engage in, such as providing actually the alcohol-based hand gels at the point of care and keeping them filled. So the target in this case shifts to the physicians, nurses, and residents who ultimately benefit from that hospital administrator's behavior, so that they depend on the hospital administrator to do that. The context for the hospital administrator changes as well. They would do that behavior probably in their office. And the time might be the initial setup, but also there may be an extended period where they need to ensure a monthly supply. So again, this is just about unpacking in detail who's involved and what specifically their responsibility or their action is, and where, when, and how often they need to do that, which will set the stage for subsequent barrier assessments. That's the hand hygiene example. Another example that might be helpful to think through is a behavior that we might want people or clinicians to do less of. For example, preoperative testing for low-risk patients. So in this case, the action might be ordering a pre-op X-ray and ECG for anesthesia management. That's performed by anesthesiologists and surgeons. And here the target is different from the last one. Rather than being all patients, by specifying the target as healthy patients undergoing low-risk surgery, such as a cataract removal, it changes how the action might be perceived as opposed to just describing it as all patients. And so, again, to highlight that making the specification changes how the action is perceived. Just to complete, the context would be in the pre-op assessment office or the clinic, for example, and it might need to be done before each surgery. So really, the TACTA is about taking time to outline who's involved, what are the behaviors they need to do, and when, where, and how often they need to perform the behavior, really to address that first point within the French framework. And we find that being this specific helps to avoid assumptions within, at the very least, within the team of investigators that are running the initiative, so that everybody's on the same page about what is actually being done and who needs to change. It also clarifies expectations from the perspective of those who might receive or be involved in the initiative in terms of the health providers, the higher order organizational players, and or the patients involved. And sets the stage for our next webinars, which is systematically assessing barriers and enablers specific to particular TACTA specified behaviors, and then selecting change strategies best fit for those barriers that were identified, ultimately to try to reduce those identified evidence practice gaps. So to summarize, producing and disseminating a review or knowledge tool or product at the end of that knowledge creation funnel within the knowledge to action framework doesn't necessarily guarantee that anyone will actually change. It is a necessary but likely not sufficient component of ensuring that whatever the evidence produced is actually implemented. And as we mentioned, jumping straight to solutions to try to implement that without fully understanding the problem, in other words, whether there are discrepancies between the knowledge product or the evidence and current practice, risks selecting a solution that's not quite matched to the issue at hand. So instead, we suggest clarifying what is, first of all, is there a gap between what the evidence produced suggests and what is actually being done? If so, who's involved? What specific behaviors do they need to change to reduce that gap, and how does that differ from what they're currently doing, and when and where should that happen? And really it comes down to removing guesswork. Breaking it down helps implementers to measure, to clarify expectations, and it sets the stage, like I say, for clarifying our barriers and enablers, which we're going to be addressing in our next webinars. Which leads me on to a plug for the next webinar at the beginning of May that myself and Andrea Patey, a key member of our team, will be leading. We'll be talking you through some of the key frameworks that we find useful as a basis for ensuring that we get a wide coverage of understanding of barriers and enablers, and that we use a consistent language so that across different studies, different assessments of barriers and enablers, we assess similar concepts. But again, in the meantime, if you have any examples of your own planned or ongoing safety initiatives that you think might be helpful for us to integrate within the upcoming webinars, please do send them our way, and we'll endeavor to do that. And that just leaves me to again, thank you all for your continued participation and interest in this, and happy to do our best to answer questions now and also by email afterwards.
Excellent. Fantastic. Thank you so much for that, Justin. And thank you, Jeremy, as well. That was a terrific presentation. I am really glad we could get you connected, Justin. The PDF for the TACT-A was definitely a popular request from our attendees, so we'll definitely make that available on our website as well. We have received a few questions from the chat box. Jeremy, I hope you don't mind, but I will direct questions to Justin since they tended to come in during his part of the presentation. However, I certainly invite you to offer your comments as well. I'll just start with Rosalind's question here. She wondered if the French model is to be used in conjunction with the knowledge to action framework, the KTA model.
I find them useful to be used together. The French model really just provides a similar, it provides a bit more depth than the knowledge to action framework in terms of the action cycle, but the knowledge to action framework provides I see that as a broader process framework that gets into the detail of the knowledge creation funnel and then outlines what to do after that, not only from identifying the problem, but the barriers and enablers and producing solutions, but it also goes well beyond that in terms of maintenance and sustainability over time, whereas the French model is a bit more specific to jumping right into assuming that we have the evidence and jumping straight into identifying who needs to do what differently, what the barriers might be, what the strategies are, and how to measure that. So it's a bit more contained, but provides a bit more depth, whereas the knowledge to action framework I see as more overarching. So I find them useful to use in conjunction.
Perfect, perfect. Maybe to extend that question a little bit, Chantal asked whether you had any suggestions for using that French model when there are competing or multiple change management initiatives on your clinical unit or in your organization.
Yeah, so that's a really good question, and something that has been of interest to me for probably the better part of a decade. What is not only competing initiatives, but basically the underlying point is the competing behaviors that need to be potentially changed, and how do those relate to each other. I don't think I have an answer to that. It's an ongoing research question for me. But what this allows us to do, I think, is, especially if it's used more broadly than in a single project, is to, at the very least, recognize that there are competing initiatives potentially and start to make links between them to identify whether, even within an organization, there may be potential conflicts, but maybe possible synergies between initiatives but this may provide a framework for actually unpacking those distinctions.
Sure, so there's value in even just identifying them. Okay. I had a question from, I'm sorry, go ahead, Jeremy. Sorry, did you have something to add, Jeremy?
Yes. Can you hear me now?
Yes, yes, I can hear you.
Sorry, I keep sounding mute on and off. So again, as Justin said, it's a really good question. It's one of the major, I think, challenges that often, first of all, just getting through a day from clinical care, clinicians are dealing with many different priorities that they're kind of juggling all the time. And then we can have these multiple sort of change processes going on at the same time. But one of the things I think this, actually mapping out, what we're trying to do using the kind of TACTA approach, it may highlight, if you like, the burden that we're putting on certain clinical groups. That actually there's 5 things at the moment we're really trying to get the kind of the nurses to look at, or the ward pharmacists to look at. And a recognition that, actually we may have to sort of think about, maybe not, or helping prioritize for those clinical staff what are most important, or actually deburdening, and maybe actually what we'll do is put this one on the back burner for a few months while we're really working on this area. The other reason it might be helpful is that you might also find that there are kind of synergies or links. We're trying to change this aspect of care, but if we do that, it might make this other thing that we're interested in also changing easier. And so again, you might think about other ways of actually joining those up more. So I think this approach might help you for both your planning of quality improvement, your thinking about the kind of the burden, the change burden we're asking clinicians to adopt, but also are there sort of potential synergies or even dyssynergies between the kind of different behaviors being targeted, which again might mean that you might prioritize or order your activities in certain ways.
I guess I'm just worried about meta frameworks being applied to research questions before we apply the actual research questions to the frameworks themselves, but it's definitely something to think about. So I did have a question from Ken. Is there a specific set of strategies for implementing behavior changes when it requires incongruence with values? He gave an example of harm reduction practices when a person believes drug use is morally wrong.
So there are certainly behavior change strategies. So I kind of see that as I lump strategies into, there are many strategies for changing behaviors, and I tend to lump them into 3 broad categories. There are some that are about getting people or supporting people to become motivated that may not be motivated for whatever reason. I think that example fits within that. There are different strategies for helping people that want to do something but that aren't doing it yet. And there are other strategies for helping people to address some of the factors that they may not even be aware of that affect what they do, the more automatic habit side of what they do. And so the question, I guess, is it's the distinction between, are there strategies for changing values? Yes, and it's a question of being selective, I guess, and judicious, and working probably with your recipient group or target group to ensure that it's an appropriate strategy to use. I think a lot of the work that we tend to do is working under the assumption or demonstrated that people want to change but aren't managing to address that, and working on the barriers at the post-motivation level, which tends to be the case when we work with clinicians. They want to change, but there are other things that get in the way. But when starting to get into changing people's values starts to be, it's not that there aren't strategies, it's whether, I guess what I'm saying is judicious use of those types of strategies or careful use of those strategies is probably in order.
For sure, but you're identifying the value as a barrier to action change rather than just trying to change the actions and leaving the values in place.
Exactly, yeah. So if there are potentially issues at the values themselves, probably need to focus strategies on getting, if it's appropriate, to change those, and realizing that that may just get to the point of getting people motivated, but may not necessarily translate into doing the thing differently.
Gotcha. Thank you very much. I have a question from Susan. Do you recommend using the root cause analysis approach to understanding problems or behaviors that need to change?
Yeah, I know Jeremy probably has some perspectives on this as well. It's not an approach that that I personally have used in the past, and usually that's because it tends to be retrospective and idiosyncratic to a particular issue that has arisen. It's not to say that it's not useful, but usually the approaches that we've been involved in tend to be a bit more prospective in nature and focusing on trying to implement or change something that's going forward rather than trying to understand a particular problem that occurred in a particular setting. But I don't see any reason why it couldn't be used to explore. I think my hesitation is really that it's is really just not the direction of inquiry that I tend to focus on. Jeremy might have some additional thoughts on that.
Yeah, Dr. Grimshaw?
Yeah, so I mean, I think it depends on whether you're sort of dealing with a critical incident, which is, yeah, as Justin said, idiosyncratic or one-off, or whether, I mean, our work is looking at sort of, what we think is being more sort of, consistent behaviours that we're trying to change. That the hand hygiene problem is not necessarily one-off, but there's multiple behaviours around that. But I think on the kind of specification of the problem and understanding the problem is common to both. And also, I think what you will, in the next few webinars, hopefully what you'll get is you'll get some more information that also about the kind of behavior models that Justin, myself, Andrea, others use to try and understand what the barriers are or the drivers of certain behaviors. And you may find that that is a useful additional lens that you could still actually also bring into some of your root cause work. So I'd see root cause is sort of saying, can we understand what were the antecedents and the drivers of whatever the critical event was. So it's very similar to what we're saying here. The question is whether some of the tools we're offering here, which are about sort of making the kind of the inquiry behavior specific, using a behavioral lens to understand those drivers, that might add value to some of the things you're doing with root cause analysis. And as Justin said, also, there are things that you can use prospectively without waiting for, particularly a sort of a major adverse event.
For sure. Excellent. Well, thank you both for that. I have one last question due to our time constraints. We are recording the other questions that come in, and we'll be forwarding them off to our speakers. But Mandy asks a two-part question that she hoped you can help us with. Part one, do you have any suggestions for how to approach the discussion about defining the who needs to do what, when, and where, if trying to simplify key program messages for a broad target audience? She gave the example of the hand hygiene program for all healthcare settings and providers. Do you have any suggestions to approach that discussion?
So how we've done this in the past that I've found helpful is to ask the various stakeholders that would be involved in the initiative to be involved in this process themselves, so to for their own actions, but also thinking through who are the other people involved that they perceive, and that's useful for two reasons. One, to clarify their own understanding or where they're at in terms of understanding their role in the process, but also for fleshing out their perceptions of who else might be responsible and have a role to play. And so almost shifting, if you have an opportunity to work with the range of different stakeholders that are involved in the initiative, getting them to be part of the process of identifying these factors rather than it being a solely desk-based exercise for the team might be one.
Absolutely. That sounds like a terrific start. Jeremy, did you have something to add?
No, very happy with it.
Excellent. Excellent. So the second part of the question is there a recommended number of practices that we should target? Should programs focus on just individual level practice or a combination of organizational and individual practices? Because there are potentially too many practices we focus on.
Yeah, I mean, so from my perspective, that sort of relates back to the potential for competing initiatives, but I guess in this case it's one initiative that has many different sort of different components, and I think fleshing out what those components are and what the implications are from a behavioral perspective may help to identify whether there are any potential conflicts or hopefully synergies between them. But I'm not sure.
I mean, so, Jeremy, one of the things I would sort of say that I mean, often when we actually sort of think about changing, sorry, got distracted for a second. When we're actually thinking about change processes, we are often dealing with multiple different behaviours. And one of the things that it's often impossible to do is sort of say, okay, for every single step of the chain, we'll actually do a barrier assessment about what's going on and what, how we can actually improve things. And so some of the issues that we get into is, can we prioritize which of the, having started with this sort of scoping perspective, and can we prioritize which are the kind of key behaviors within a chain of behaviors that will be important for the delivery of the safe practice. And so some of these things there, it becomes a bit of a judgment, but might be in terms of what are the kind of mission critical sort of behaviors that, if they're not in place, it means that our safety practice will not work through. Are there certain orders in which things have to occur? A has to happen before we can think about doing C. And so I think you could start off with a kind of an initial scoping practice to understand what the various different sort of behavioral components are of the change process, and then think about prioritizing within those to do your barrier assessment. I think also implicit in the question was the idea that sometimes if we try and change everything all at once, it just becomes overwhelming, and often we fail because the organization or the individuals just can't manage with such a broad-based change. And that's something that I think has a great deal of face validity. It's something that I think my guess is most people on the call would recognize as being a challenge. I don't think there's any good evidence about sort of what the natural number of things to address are, but I think we should be cognizant, and it may be better to focus on a small number of changes and make sure they occur, rather than sort of trying to say we'll change everything and then basically just getting into a morass of change processes where everyone is really struggling to enact what we'd like to happen.
For sure, for sure. Focus on priorities and focus on the things that you can achieve first and foremost. I get it. Thank you both so very much. I see we're at time, and we do want to respectfully thank Drs. Grimshaw and Plesseau for sharing your time and your expertise. And of course, thanks to all of you for taking the time to attend. We know how busy your day is, and we appreciate you choosing to spend time with the Canadian Patient Safety Institute. Please visit our website for a taped version of the presentation today and to sign up for our next Knowledge Translation and Implementation Science webinar. On May 2nd, as mentioned by Justin, we will come back with Dr. Plesseau and either Dr. Nicola McCreary or Dr. Andrea Patey to discuss identifying barriers and enablers to implementation. If you wish to sign up for this upcoming webinar, or if you want to continue the conversation started in this discussion, please feel free to send us an email. We will forward your comments and any questions you may have had that were unaddressed on to Drs. Grimshaw and Plesseau. You should all receive Monique Thibodeau's follow-up thank you email in your inbox shortly, and you can respond to that. Thank you again. Have a wonderful day, everyone, and we will hope to see you again soon.
Thank you, everyone.